Welcome to the latest installment of the AST Journal Club series. Today's session features the CJ-ASN article, Living Donation and Pregnancy-Related Complications, State of the Evidence and Call to Action for Improved Risk Assessment. This session is sponsored by the AST Women's Health and Living Donor Communities of Practice and highlights work from the 2023 WHCOP Virtual Controversies Conference on Reproductive Health, Contraception, and Pregnancy After Transplantation and Living Donation. In a moment, I will turn the session over to our moderators, Dr. Nadeen Khoury from Henry Ford Health in Detroit, Michigan, and Dr. Tiffany Caza from Arkana Laboratories in Little Rock, Arkansas. But before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. We encourage you to use the Zoom chat function during the Journal Club to share your thoughts and comments. However, if you have a question to submit to our panelists, we strongly recommend using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. This Journal Club is being recorded, and the archive will be available on the MyAST website and AST YouTube channel in 2 to 3 business days. Finally, when you log off at the conclusion of today's Journal Club, you will see a link to a short evaluation survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderators, Dr. Khoury and Caza, to begin our presentation.
Welcome, everyone, and thank you for joining us in today's Journal Club hosted by Women's Health Community of Practice and the Living Donor Community of Practice. In this session, we will be discussing living donation and pregnancy-related complications, state of the evidence, and call to action for improved risk assessment. It is a great pleasure to be moderating this session with Dr. Caza and a great honor to have our speakers, Dr. Rossi and Dr. Lentine, join us to discuss this paper, which is the product of a controversies conference held in 2023, focused on reproductive health, contraception, and pregnancy after transplantation and living donation. Without further ado, I will start by introducing Dr. Rossi. Dr. Anna Rossi is a transplant nephrologist at the Piedmont Transplant Institute. She serves as chair of the AST Women's Health Community of Practice, where she advocates for gender equity in transplantation and advances reproductive health for both donors and recipients. Dr. Rossi is also an active member of the Living Donor Community of Practice and co-chaired the AST Controversies Conference on Reproductive Health, Contraception, and Pregnancy After Transplantation and Living Donation. And now I will hand it over to Dr. Caza to introduce Dr. Lentine.
Hello, everyone. I am pleased to introduce Dr. Lentine. And Dr. Lentine is a professor of medicine at the St. Louis University Hospital, and she serves as the vice chair of internal medicine research and is also the associate director of the nephrology department and the medical director of living donation at their transplant center. She's also an avid researcher and has authored or co-authored over 300 peer-reviewed publications in topics of transplantation, organ donation, and access to care. She is a member of the Women's Health Community of Practice, served as the past chair of the Living Donor Community of Practice, is senior staff of the SRTR, and also been an integral part of the OPTN. She focused much of her work on living donation, and she has co-chaired the 2017 KDIGO Living Donor Guidelines, which provided guidance to transplant professionals everywhere in their evaluation and care of living donors. In addition to all this, Dr. Lentine is one of the most inspiring and motivated people that you'll ever meet, and she's really working toward positive change in kidney transplantation and empowering others with opportunities to be active contributors as well. And today they're going to present the results of a recent publication in CJASN as the work product of a recent conference in AST's Women's Health Community of Practice. And so thank you so much, Dr. Lentine.
Here are the disclosures of our speakers and both moderators. And this is the paper.
We'll start with a case. Our first case is of Sarah, and she's a sister that has had a history of preeclampsia, looking to donate to her 45-year-old sister who has a history of end-stage kidney disease due to hypertension, but has not yet had a biopsy or had never had a pre-transplant biopsy. Sarah's history includes 2 pregnancies. The first was uncomplicated, but the second, she developed preeclampsia at 34 weeks, although did deliver a healthy baby by an emergency cesarean section. As far as family history, there's no other significant history except her sister with a kidney history of end-stage kidney disease. And her donor evaluation was fairly normal. She has a normal BMI, normal renal function, and was without proteinuria. Her blood pressure is normal. She underwent APOL1 genotype testing of being of African descent and only had 1 risk variant, so a low-risk APOL1 genotype. And so Dr. Khoury? Oh. And so some questions to the group and to be looked at throughout this discussion is, would you be in favor of Sarah being a candidate as a donor? And what counseling may you provide for her in general and with her reproductive care?
Our next case is the case of Maria, the friend with a history of depression and gestational diabetes. Maria is a 30-year-old Hispanic woman. She wants to donate to a close friend who has end-stage kidney disease secondary to lupus nephritis. Maria's pertinent history includes depression, currently well controlled on 1 medication and therapy. She's had 1 pregnancy at age 27, complicated by gestational diabetes, managed with diet and exercise. She delivered a healthy baby at term via vaginal delivery. No pertinent family history. Current medication include fluoxetine. Her BMI puts her in class 1 obesity. She has normal kidney function, normal A1C, absence of proteinuria, and her creatinine clearance was normal. She is concerned about her depression post-donation. What would you tell her? What about her history of gestational diabetes? Is that concerning for you? And now I hand it over to Dr. Rossi.
Hello, everybody. Thank you, Brian, for the introduction, and thank you, Nadeen and Tiffany as well. We are excited to be here today presenting our work. So thank you, AST, for the invitation, and also thank you for all the support that we receive in terms of all the logistics, all the preparations that took place so our Controversies Conference could happen. So let's see if I can advance the slide. There we go. And so let's dive in why pregnancy is an important aspect of the living donor evaluation. So living donors help bridge the gap between the need for kidney and liver transplant and the supply of deceased donors. Women represent the majority of living kidney donors and living liver donors, and women of childbearing potential represent 40% of all living donors. So a large proportion of living donors have the potential for their post-donation health to be affected by pregnancy. Women wishing to become a living donor frequently ask whether donation will affect their future pregnancies. And clinicians, on the other hand, often ask if pre-donation pregnancy complications impact the suitability to donate. So to address pressing topics like this related to reproductive health in living donors, but also in solid organ transplant recipients, the AST Women's Health Community of Practice held a virtual Controversies Conference that took place in February of 2023. Experts met for 2 days to discuss the topics of parenthood and reproductive health in living donors and in recipients. The conference has 3 major objectives that you can see listed there, with the third one related to pregnancy recommendations surrounding living donation. And that is what we are going to be showing you today, the work product of our meeting. So the WHCOP Controversies Conference participants, all of them are listed here. You can see their specialty and the area of expertise. The group was divided in 3 different work groups, with the work group number 3 listed here being the participants that participated in the living donor piece of the conference, where we discussed the available data related to pregnancy complications, and also pre-donation pregnancy complications that can affect the long-term outcomes of our donors. And this is the group in action. It was a 100% virtual conference. So for today, let's focus on the objectives for today. We are going to review key data related to risk of pregnancy complications in living kidney donors and living liver donors. We're going to review key data related to the downstream clinical impacts of pregnancy complication in living kidney and liver donors. We're going to review the available policy and guidance, and we'll consider the next steps, including recommendations to gather the much needed data. What are the possible implications of donor nephrectomy? Why is this important? So from animal models, we know that one kidney physiology versus a two kidneys increases the blood pressure and also increases the risk of proteinuria. We also know that in general, kidney donors lose about 35% of their GFR, and a reduced GFR increases the risk of preeclampsia. Now, in terms of regarding the risk of hypertension for donors, this is a little more difficult to elucidate as the data is conflicting in this aspect. But in general, not in living donors, but in the general population, we know that a lower GFR increases the risk of maternal morbidity, preterm delivery, and also the risk of low birth weight. But the issue is that most donors are really not represented in this population because donors tend to have a GFR above 70, and we all know that they are healthy. And so a population with CKD is not a good comparison group.
Thank you so much, Anna, for that great background and introduction so far. So let's go ahead and move from the general population to information from donors. And here is an important paper that set the stage for living donor care for a number of years. In 2004, an international consensus conference on living donation was held called the Amsterdam Forum. And the goal of this forum was to address gaps for practice and guide care. But due to limited evidence, many recommendations were opinion-based. And among the expert opinions, the conference attendees concluded the donor nephrectomy is not detrimental to the prenatal course or outcome of future pregnancies. And the resulting document was widely used to inform the evaluation and care of living donors. However, subsequently in 2009, two studies found higher rates of gestational hypertension and preeclampsia in groups of women with pregnancies after versus before donation. However, the methods and findings were debated, and many programs did not incorporate this newer information in their informed consent processes. Next slide, Anna. So over the last decade, frameworks of risk have been recognized as critical for evaluating evidence for donor evaluation and counseling. Pre versus post-donation and general population comparisons do provide some information if interpreted appropriately. But to get at attributable risk or the risk due to donation itself, we need to compare donors to similarly healthy non-donors. In other words, a central question for understanding the impact of donation on pregnancy outcomes is, do living donors, compared to matched healthy non-donor controls, have a higher risk of gestational hypertension and preeclampsia when followed for years after donation? Next slide, Anne. So an important study attempting to quantify attributable risk specifically for living kidney donors was published in the New England Journal in 2015, led by Dr. Amit Garg in Canada, and I had the privilege of being a co-author. In brief, study data were drawn from an integrated transplant and healthcare databases in the province of Ontario. We identified living kidney donors in the province and selected women, and this is important, with no prior history of gestational hypertension who had at least one pregnancy carried to 20 weeks or later. And healthy non-donors were identified by screening out conditions that would preclude donation. And then each donor was matched to 6 non-donors according to baseline characteristics that might be associated with risks of gestational hypertension. Next slide, Anna. And we found that gestational hypertension or preeclampsia was identified in 11% of donor pregnancies compared with 5% of controls, yielding an odds ratio of 2.4. However, there were no significant differences between donors and non-donors with respect to secondary outcomes, including rates of preterm birth or low birth weight. And importantly, there were no maternal deaths, stillbirth events, or infant mortality in either group. And you'll find next slide, Anna. Thank you. With regard to clinical sequelae of hypertensive disorders of pregnancy, in both donors and non-donors, rates of cesarean section were higher in those with gestational hypertension and preeclampsia compared to pregnancies without these conditions. The proportion of donors with a low birth weight delivery was also higher when gestational hypertension was present compared to when it was absent, about 8-fold higher, similar to the 6-fold higher proportion in non-donor pregnancies, though the counts in donors were not reported due to small numbers. But overall, donor complication rates did not differ from that of controls. And in 2022, PPS et al. Published a systematic review of pregnancy after living kidney donation. Overall, they found preeclampsia in 4 to 10% of pregnancies after living kidney donation versus 1 to 3% pre-donation, and 1 to 5% in healthy non-donors. Next slide, Anna. And the risk of adverse fetal and neonatal outcomes was not different in living kidney donors versus pre-donation pregnancies or versus controls. But the review also pointed out limitations of available data, including small sample sizes, the retrospective nature of the data, often acquired by chart review or questionnaire with the associated risk of recall bias, and factors impacting pre versus post-donation comparison, such that donors are older after donation than they were before donation inherently, as well as concerns with regard to selection in the candidates with a history of preeclampsia may have been declined from donation. So let's shift to living liver donors, an important group that needs a call to action for more data. And in fact, a key inference is that current evidence is limited for this important group. So one study from Japan focused on concerns among living liver donors for pediatric patients, noting that half of these living donors are mothers. This was a qualitative descriptive study examining the experiences of 11 women who became pregnant after and gave birth after living donation. And the women expressed a number of important concerns, including a desire for information on pregnancy and childbirth after donation, and access to consultants with whom to discuss these concerns. The mothers also reported concern for physical and mental burden after donation, including concern for the health of their recipient. But to date, there are minimal robust data to counsel on pregnancy outcomes in this population. However, providing a supportive framework for women who are both donors and caregivers should be a priority. And Drs. Sonnenberg and Lee have been working on generating outcomes data by conducting a multi-center project with a report published in Liver Transplantation. They found increased reporting of abnormal liver enzymes and cesarean sections in post-donation pregnancies, but otherwise there were no significant differences in pregnancy outcomes before and after living liver donation. The study does have limitations as a retrospective survey, and it did lack healthy control comparators. And thus the authors advocate for continued monitoring of pregnancy outcomes across larger cohorts of donors. And now we'll turn back to Anna.
Thank you, Krista. Okay, so now we heard that preeclampsia is more common in living donors. So the question is, what can we do to prevent preeclampsia? So data from in non-donors from randomized controlled trials and meta-analysis demonstrate moderate reduction in preeclampsia rates with the use of aspirin. The general OB guidelines state that based on maternal risk factors, pregnant women identified to be at high risk for preeclampsia should receive low-dose aspirin, starting ideally in the first trimester until labor or the 36 to 37 week of gestation. And the recommended dose varies between 75 to 162 milligrams per day. The recommendation for living donors that become pregnant is to start aspirin 81 milligrams nightly from the 12th week of gestation until delivery. And this is supported by the 2018 British Transplant Society and Renal Association of the UK guidelines for living kidney donors. Why is it important to prevent preeclampsia and gestational hypertension in the general population? So this is from the general population, so we are talking about non-donors. We know that hypertensive disorders of pregnancy are associated with an increased risk of hypertension, coronary artery disease, and stroke later in life. This is from a very large study that included almost 10,000 pregnancies, and you can see the significant increased risk for all those three outcomes. Now, also in the general population, so in non-donors, there is information for this very large meta-analysis that included 23 articles. They show that preeclampsia and gestational hypertension were associated with an increased risk of chronic kidney disease greater than threefold, and also end-stage kidney disease almost fivefold. And when chronic hypertension was associated with preeclampsia, the risk of end-stage kidney disease was significantly increased with a pool ratio of 44. Now, let's review the data that is available in donors. So this is data on donors who had a pre-donation pregnancy. This study of mostly white non-Hispanic donors involved a little bit over 1,800 living kidney donors that had a pre-donation pregnancy and that they were followed for a median time of 18 years. So in this study, gestational hypertension before donation was associated with an increased risk of developing post-donation hypertension. Gestational diabetes before donation was associated with an increased risk of developing post-donation diabetes, almost a threefold increase. But in contrast to the general population, living kidney donors with pre-donation preeclampsia or eclampsia did not have a higher risk of developing hypertension or chronic kidney disease. But there was a trend towards an increased risk of cardiovascular disease. So it is important to know that these risks are not higher than in the general population. So the risk is increased, but it's not higher than in the general population. And none of these pre-donation conditions were associated with a reduced kidney function as defined by eGFR of less than 45. So that's the green box that you can see there. Now, an important limitation of this study, beyond the fact that it was mostly a white population, is that these donors donated on average 10 years post-donation. So it is possible that if a donor developed a reduced GFR or they develop hypertension after donation, they were not included in this study because they were more likely excluded as donors. So we don't really know the whole story. Now, another study that we have available in donors from the same group, from Dr. Maras, it was basically a cohort of the prior study that I showed you. So this was also a single center, mostly white, that involved almost 400 donors. And they found that gestational hypertension and preeclampsia were associated with hypertension later in life. Also, the development of preeclampsia and gestational diabetes were associated with the development of diabetes later in life. But most importantly, as you can see in the green box, none of these pregnancy-related complications were associated with an increased risk of cardiovascular disease or with an eGFR below 45. What about the risk of postpartum depression? Post-donation depression is a known phenomenon with a prevalence between 5 to 23%. Risk factors for post-donation depression include pre-donation depression, a greater financial burden, younger age, a negative recipient outcome like graft failure or death, short-term medical complications, and single marital status. The prevalence of postpartum depression is about 7 to 15% and is a leading cause of maternal morbidity and mortality. Preeclampsia increases the risk of postpartum depression, and it also increases the severity of symptoms. What we don't know is if living donors who become pregnant have an additional risk of postpartum depression, or if living donors who develop preeclampsia have an additional risk of postpartum depression. There's really no data available to answer that question. Regarding the financial burden of becoming pregnant after living donation, there are no specific data on this. We know that living donors in general have financial struggles that are frequent due to need to take time off work, travel costs, and lost pay. Healthcare and affordability and general finances stress are commonly reported by women in the peripartum period. And pregnancy-related complications can increase the cost of medical care. But we really don't know if women that become pregnant after donation have an increased financial burden. What about the timing of pregnancy? How long should a living donor wait between donation and conception? During pregnancy, there are many physiologic changes that affect the kidney, the liver, the lungs, and the heart function. The goal should be to preserve excellent remaining organ function in donors during pregnancy, and there's really limited data to guide us on how long to wait. The rationale to delay pregnancy post-donation is to allow kidney function to compensate and stabilize before subjecting the remaining kidney to a new hypofiltrating state. In the case of the liver, is to allow the liver to regenerate, which happens mostly in the first 6 months, but it continues to do so through the whole year after donation, and also to attend to the psychosocial needs of the recovering donor, but also of the expecting mother. Additional factors that need to be considered are the age of the mother in terms of how this can affect her fertility. So from the 2005 Amsterdam Forum report, the recommendation was to wait at least 2 months. In 2009, there was expert opinion published that recommended to wait at least 1 year. And our recommendation is to wait at least 6 months between donation and conception. So in summary, what has the data shown us so far? Living kidney donation confers a small but real increased risk of preeclampsia and hypertension. From limited data that I show you, mostly on white population, we know that gestational hypertension and gestational diabetes pre-donation increase the risk of hypertension and diabetes later in life. But different from the general population, gestational hypertension, gestational diabetes, and preeclampsia are not associated with a GFR below 45 in this donor. So this is super important. And data from non-donors, so from kind of what we consider the general population, we know that preeclampsia increases the risk of hypertension, ischemic cardiovascular disease, chronic kidney disease, including end-stage kidney disease later in life, and postpartum depression. For living liver donors, there is an increase of C-sections and elevated LFTs after donation. And both for liver and kidney donors that become pregnant, the psychosocial outcomes are less clear. And now I'll turn it back to Krista.
Thank you so much, Anna, and what a wonderful summary slide putting all that complex information together. Thank you so much for that. So now we'll move to consider, what do the guidelines say about the impact of prior preeclampsia on candidacy for donation? We've been talking about the Amsterdam Forum today, and after that forum, there were other local and regional guidelines. For example, in Canada, the 2014 Kidney Paired Donation Protocol opined that premenopausal potential donors with a history of preeclampsia within 10 years, or preeclampsia in recurrent pregnancies, or a history of preeclampsia and planning future pregnancies should be excluded from donation. By comparison, in 2017, the KDIGO Living Donor Guideline considered all the guidelines available to date, but ultimately took a more personalized approach and deemed that women with a prior hypertensive disorder or pregnancy may be acceptable for donation if long-term post-donation risks are acceptable. Although notably, the guideline left determination of acceptable risk to the center, and part of that weighs on the fact of the need for more evidence. Next slide, Anna. With regard to gestational diabetes history, the Australian Kerry guideline deemed that gestational diabetes mellitus is an absolute contraindication to donation, so fairly stringent exclusion criteria. But by comparison, the KDIGO guideline recommends performing glucose tolerance testing or hemoglobin A1C in women with a history of gestational diabetes to define current glycemic control, but then recommends that the decision for approving a candidate found to have prediabetes or type 2 diabetes mellitus at the current time of evaluation should be individualized based on overall risk profile, but again, without a discrete threshold for what that risk threshold would be in terms of numerical terms. Next slide, Anna. So synthesizing what is available, contemporary donor counseling should include informing women that there is a small but increased risk of gestational hypertension or preeclampsia after kidney donation. And in fact, in the United States, based on the data that we have been reviewing, OPTN policy requires that we must share this risk in our informed consent with donor candidates. However, the risks of adverse fetal and neonatal outcomes do not appear to be impacted by living kidney donation. And with regard to long-term impacts, those who develop post-donation gestational hypertension or preeclampsia may have increased risk of hypertension later in life. For living liver donors, what we know so far based on the Sonnenberg and Lee study is that the frequency of abnormal liver enzymes and C-sections may be higher in post-donation versus pre-donation pregnancies. But importantly, no healthy control comparisons have been reported. Next slide, Anne. For women with a history of pre-donation pregnancy complications, women kidney donor candidates with a prior history of preeclampsia, gestational hypertension, or gestational diabetes should be counseled about the potential higher risks of preeclampsia in subsequent pregnancies, the higher risk of hypertension and diabetes later in life, and potential higher long-term risks of cardiovascular disease and chronic kidney disease. But critically, it is unknown whether donation changes the long-term risks of these conditions. And also, very importantly, there are no corresponding data for living liver donors. Next slide, Anna. So we wanted to take a moment to call out that the AST Living Donor Community of Practice has created a medical toolkit with a pregnancy chapter, and there are both patient-centered and clinician-focused versions of these chapter, with the patient focus being carefully edited for health literacy. The counseling recommendations are similar to the KDIGO guideline and what we have been discussing, including that we feel that women should not be excluded from donation simply because they wish to have future pregnancies, but they should be counseled, provided the information that we know so far, and supported in informed decision-making. And the document also explicitly calls out the need for more research among subgroups to tailor counseling, including, for example, among Black women and women of color who've not been well represented in the studies to date. And ultimately, we believe that there is a need for more data collection focused specifically on the pregnancy outcomes of living donors and donor candidates. And this should include detailed information on pre- and post-donation pregnancy history and related clinical parameters. And to achieve this end, we feel that there is a need for registries. Efforts like the SRTR Living Donor Collective may be a mechanism for gathering these important data for our women donors. And if you're not familiar with this, the Living Donor Collective is an effort to develop a donor candidate registry. So the data collection starts with candidates and then follows forward, and pregnancy outcomes has always been a topic of interest. Currently, that project is working on some potential collaboration with the OPTN to start the donor candidate data collection within the OPTN framework, but more to come on that effort. And with that, we are going to turn to our moderators to return to some analysis of the cases that we've been discussing based on the data so far. And then we look forward to your engagement through the Q&A. So Tiffany, Nadeen.
Thank you, Dr. Lentine and Dr. Rossi, for an excellent presentation. Going back to the first case of Sarah. So Sarah wants to donate to her sister who has end-stage kidney disease secondary to presumed hypertensive kidney disease. So looking through Sarah's candidacy, some favorable points to highlight, which would be supportive of Sarah's candidacy for donation. She has normal kidney function, no proteinuria, normal blood pressure, acceptable BMI, low risk genotype for APOL1, and a strong motivation to help her sibling. However, given her history, there are some considerations that warrant detailed discussion. Sarah has history of preeclampsia in her second pregnancy, which increases her long-term risk of hypertension and cardiovascular disease. Her family history of kidney failure in her sister, even if presumed to be hypertensive kidney disease, the possibility of shared susceptibility is still there. However, we mitigated that by doing APOL1 testing and verifying that she has low-risk genotype. Weighing the favorable points and looking at the consideration and some of the risk factors, Sarah should not be contraindicated to donate. She should be considered as a donor, in my opinion. However, she falls into a moderate risk category where counseling and informed decision and shared decision making is important. She should be counseled in detail about the risk of chronic hypertension, cardiovascular disease given her history of preeclampsia, and she should be aware of the risks of gestational hypertension and post-donation preeclampsia. So that would be kind of my take on this case. Any input, Dr. Rossi, Dr. Lentine?
Just Dr. Actually to all my co-panelists with regard to the blood pressure evaluation, what measures do you need to make that determination of blood pressure within normal limits? And I'll just expand that in my practice, we routinely use a 24-hour ambulatory blood pressure monitor to make that confirmation in any woman with a history of preeclampsia. So just wondering how you folks feel about that.
We do a ambulatory blood pressure monitoring, 24-hour ABPM for confirmation. Yeah.
Yeah, that's an excellent point. We actually do a couple of blood pressure checks during the evaluation, and some before they come for the evaluation, but our practice has been to do the 24-hour only if it is elevated, at home on random checks or office visits. Mhm.
Excellent. And we are getting some questions kind of related to these themes for liver donation, but maybe we'll do the next case and
The
then
next
move in.
case
I'm watching the
quickly.
chat too.
Yeah. Okay, so we can move to the next case quickly to kind of go over Maria's case. Maria, who's a 30-year-old Hispanic woman, wants to help her friend. She has history of gestational diabetes, diet controlled. She also has history of depression. So she's concerned about her depression post-donation. And our concern is if her gestational diabetes would preclude her from donating. So reviewing the case, some favorable points in terms of her candidacy, again, normal renal function, absence of proteinuria, and normal A1C. However, some risk factors are in her history, like I mentioned, the gestational diabetes, which would increase her future diabetes risk, but also her BMI, which puts her in the class 1 obesity category. Since she is motivated to donate, and currently her A1C is within normal limits, I wouldn't see a big objection to her being a donor. However, she should perhaps be strongly counseled on weight loss, healthy lifestyle, diet modification, incorporating exercise, moving on this path of a healthy lifestyle overall, and show evidence that she can lose weight and not gain additional weight. That will make me feel more comfortable allowing her to donate. With regards to her depression and her concerns about her depression after donation, it seems her depression is pretty well controlled. She has not any hospitalization related to suicidal ideation. She follows with a therapist. And if our transplant psychologists evaluate her and social work prior and they clear her, I don't see it being a concern for her donating. However, again, she should be counseled on the risk of depression post-donation, and she already has depression, so that will kind of increase slightly her risk. And also she should be aware of the risk of postpartum depression, so she is able to make an informed decision. Any additional input, Dr. Lentine or Dr. Rossi?
No, I think that was a great synopsis, Dr. Khoury. The A1C right on the border of pre-diabetes. We tend, and this is just kind of Lentine practice. It's not evidence-based. I tend to do a 2-hour glucose tolerance test, and these folks just as well for additional stratification. I very much agree with what you said about the weight management. So she's not, the BMI is not in the morbid or the very obese category, but it's definitely greater than 30. So would look on that, with her about trying to come up with a weight loss goal as well.
Excellent. Yeah. And I guess we have a question. Oh, go ahead, Dr. Rossi.
No, I was just going to say, I agree. I think you did a very good summary, and how these two cases are, a great example of shared decision making and how we need to communicate that risk and make the candidates participate in the decision, because people accept the risk in different ways. And so something that it may not be acceptable for us, it could be an okay risk for them. So our job is to guide them on that decision. I just want to go back to the other case just for a minute and get your opinion on any additional genetic testing. So, we have Renaside, we have the option to do so much genetic testing. So would you guys consider on the intended recipient, the sister in this case, to do maybe a Renaside panel, and then if she tests positive for something, then maybe do it in the donor, so to check beyond APOL1, because she's still young, 32.
I want to pull that out. Well, you kind of just cited my center's protocol. I think it's okay to shout out. So there's a very recent publication in Transplantation related to the protocol that we do for genetic testing at St. Louis University, led by Dr. Fadi Abu al-Rab and Yasser Keliscan. And our protocol on the recipient side does include offering genetic testing to folks who have essentially and I'd be interested in Dr. Caza's input as well about the diagnosis here, but hypertension is not a clear diagnosis. So without a biopsy, we do offer genetic testing, and then the downstream for that, we do ancestry-based testing for APOL1 in all candidates. So I agree with doing that here, but then focused familial testing if there's any pathogenic variants identified in the recipient. So yes, I would have done that, Dr. Rossi.
I love your approach to it too, of looking at the recipient's genetic panel first, because variants of undetermined significance are very common and they're tough to know what to do with. And so if you have the same VUS in a donor and a recipient, it may be concerning, but otherwise there's a lot of background noise in people with normal kidney function. So I really like how you handled that there. I had a question that was brought up in the chat that's related to this case. And Dr. Rao had mentioned, is aspirin recommended for all post-donor pregnant women, or are there other individual patient considerations? I saw this patient had a prior preeclampsia, but because of the increased risk in preeclampsia compared to non-donors, when do you use aspirin therapy?
Yeah, so we are extrapolating the data here from non-donors, right? And so for the kidney donors, they are considered high risk, because the risk, as Dr. Lentine showed us, could be up to 11%. So for those donors, I would recommend the use of aspirin starting at 12 weeks of gestation. And when we met in the conference, there were various opinions. Should it be 81 milligrams only, or should it be 162? And so you could, and I know B may further re-stratify that and say, well, maybe this donor should be on 162. But we felt as a group that 81 milligrams daily, starting at week 12, was indicated. For living donors, we really don't have the physiology, we don't have the data that we do for kidneys. We thought that it probably wouldn't hurt, but the recommendation is a little bit harder, I think, to do. I don't know, Krista, if you have other thoughts on that.
No, I was wishing that we had a liver expert on here, but basically I think there's the main thing that we wanted to call out from this is just that there's a substantial lack of evidence for the living liver donors, and we think that's a group that needs a lot of attention. And even the one study of which we use for the crux of some recommendations in the paper, it's a survey-based pre and post donation pregnancy comparison. So there's certainly limitations in that, and then no non-donor controls. So liver in particular is a group that's very ripe and in need of registry efforts. And so we'll call out to that. And regarding the aspirin use recommendations, yes, when the general population data came out, we certainly flagged that. I was watching that very closely. We had some good OB-GYN experts as part of the controversies conference panel, and they were very comfortable extrapolating that data for kidney donors. So I've adopted that into our practice, and we think it's appropriate. And then we'll let the moderators do it, but there's more questions about this case.
Yeah, so Dr. Gandhi had mentioned, would you allow Sarah to donate if she was still considering an additional pregnancy in the future, and how would you counsel her?
That's a tough one.
That's a tough one.
That's a tough one, because from the general population, like even if she's not a donor, from the general population, we know that in further pregnancy, she have a higher risk of preeclampsia. And then when you are compounding more I didn't show you that data, but there's data that when you're compounding more and more preeclampsia episodes, then the risk of end-stage kidney disease goes up exponentially, and so being 32, and she seriously won other pregnancies, I will be cautious, honestly. I will worry about that. And, and I don't know what would mean in terms of, sometimes we say you know, think about having your babies, and then maybe later on you can be the donor, you know. And so that would be something to consider depending on how, you know, her future pregnancies go. Yeah.
I just think it's a great question, and I think those are the kind of things that, you know, as we're performing our evaluations of donor candidates, that we have to be asking about their plans for future pregnancies, and then providing all the information. And I agree with Dr. Rossi and all of you. We would need to provide her that data very carefully. You know, if it's a family situation and there are other potential donor candidates available, kind of give that shared decision making and say that, you know, perhaps another candidate would be more suitable, and then if your recipient needs a transplant later on, to reconsider that. But, you know, at the end of the day, if she pushed really hard, if she was the only donor and she was absolutely informed and wanted to do it, I might consider it if, yeah, her weight is good, with all that counseling and informed decision making.
Great.
And
Thank you.
for these
Another question
patients-
from,
sorry.
oh, go ahead. Go ahead.
And for these patients who desire future pregnancy, would you refer those to high-risk OB? Is that a question from Dr. Clin in the chat on that?
Who wants to answer that first? Well, what I do is just make sure that they're very well plugged into care, and people have different requirements regarding requiring donors to have insurance. You know, I wish that the health system provided to all donors. It's sort of another topic, but so we want our donors to have insurance. We tell them about these risks, and then say, you know, if you do become pregnant, to hook into your care, you know, early, make sure that they know you have a single kidney. But I don't require them to go to high risk OB or recommend that. But then, and then we also communicate the aspirin recommendation at the appropriate time.
Yeah, I think it really depends on where you are practicing and what's your available, you know, expertise. And, you know, in truth, it's very rare that we see these donors back. You know, I just had a living donor that came out for a regular checkup last week, and we learned that she was, you know, like, I think 14 weeks pregnant. But I think she's one that I remember because they're so rare. So I would counsel them, you know, when they come and see us, and of course they're not thinking of pregnancy at the time of the evaluation, but I always try to tell them the information about the aspirin and to seek a high risk OB, because I'm not sure that every OB will know about that, you know, but it may not be available where you are. So I think the best we can do is, you know, educate them.
Along those lines, a question here about living donors. Are they all considered to be high-risk pregnancies, living donors who get pregnant?
Living kidney donor, well, I mean, based on the data. So again, I just in my practice, I don't recommend that they see high risk OB, but we do. The risk is enough to warrant the low dose aspirin for, and then I explicitly, if you know, of course, and we're required by OPTN, share the pregnancy data, make sure they're aware of that. I guess things are different. We try to maintain contact, so I'm aware of a number of our women actually who have become pregnancy, and often, you know, pregnant, and then they'll come back and share the outcomes with us. It's kind of an exciting thing. So I don't formally make them say the question, Dr. Khoury, we don't make them see high risk OB, but apply the aspirin data and try to follow up with them.
And then one more question. Can you please comment on the financial hardship and, you know, financial burden after donation? We don't talk about that much when we see our donors in clinic. This is a topic really we don't touch on. How is that, how loss of wages and loss of employment can affect post donation pregnancy outcomes? And is there a way to kind of pinpoint that at the time of evaluation and find ways to risk mitigate?
And dependent care, so not just wages, but, you know, a wonderful thing. We're big advocates and heavy users of the NALDAC program at the National Living Donor Assistance Center, which had within the last couple of years a great update to move from not only covering travel and lost wages, but to also, not only covering travel and lodges, but to incorporate coverage for lost wages and dependent care. It currently is the means testing for qualification is based on the recipient. Folks are probably aware there's a number of policy proposals on Capitol Hill to change that from the recipient to the donor, or the person who actually has need, but they did, the NowDec program was able for non-directed donors to change it to the donor themselves. So that's a great program. We make sure that every donor is screened for potential eligibility for NowDec. And I've actually have had a number of young women where it's been extremely helpful. They've need the coverage just to get childcare to, come to their evaluation appointment. So using the cost mitigation programs that are available optimally is at least one thing that we can do. And then, of course, advocating for maximal.
Yeah, excellent. Thank you.
And I don't know, Dr. Caza, if you had any comments just around kind of from your unique perspective about psychosocial supports for donors and candidates and women, do you feel like we're doing enough? Do you have any other ideas that could be offered?
I think you guys are explaining things beautifully, and I know that you both are experts in this area and in counseling living donors, so thank you for sharing your perspectives. But just knowing the individual needs of that person who can vary substantially. I think that transplant coordinators, if they have dedicated support, the center sometimes do a good job of that, and maybe they're the main point person through this whole process, and really can develop a relationship with the transplant coordinator throughout that. But that individualized approach is important.
If it's okay, I think someone had asked, is the Transplant Pregnancy Registry International, is that tracking post-donation? Is that Lisa Cosia's? There is a transplant recipient registry, and I'm speaking out of my authority because I'm not part of that, but I know that the one particular registry that Lisa runs doesn't include donors at this time.
Correct. Yeah, I think they're referring to the TPRI, and I don't includes donor. You're right, Krista.
Right. So there is a big, and if folks do look at our publication here from the Controversies Conference, a big consensus of the whole work group was we put together the data available to the best possible, but there are big data gaps, and we felt very strongly that registries that focus on these important outcomes for women is very seriously needed. That was and of course for kidney, and then the big evidence gaps for living liver donors.
So we put together this visual abstract just as a summary of the AST Women's Health Community of Practice having a virtual controversies conference to address the issue of pregnancy-related complications post-living donation were fairly unknown. And a big focus of the conference was to identify data elements to be collected moving forward to be able to provide more guidance, since a lot of the literature that Dr. Lentine and Dr. Rossi described were from studies from non-donors being extrapolated into living donors. But some take-homes were that if you had gestational hypertension or diabetes, that increases the risk post-donation, but it's not any different from non-donors in those cases. However, there was an increase in preeclampsia rate compared to healthy non-donors. And low-dose aspirin may reduce that risk, but again, that's extrapolation from studies of non-donors, that large study in the New England Journal of Medicine. And there was an increase in frequency of C-sections post-donation in liver donors as well. That was something else that had come up upon literature review. And there's really a need for further data collection and registries to better understand and counsel donors.
We just want to compliment Dr. Caza and Dr. Liajad again for this wonderful visual abstract. We'll be sharing this out in different media contexts, but
Absolutely.
Puts everything together and it's beautiful.
Thank you so much. Yes, I love it.
All right. Well,
Any final comments, Dr. Lentine, Dr. Rossi? I think we're close to ending.
I think we
time.
just wanted to thank everyone to thank our wonderful moderators, Dr. Khoury, Dr. Caza, for doing just such a great job running the program. Thanks to Dr. Rossi for her leadership of WHCOP and leadership of the conference and getting these wonderful papers out from the LDCOP. Just thank you for cross-COP collaboration. That's been extremely valuable to us. Dr. Rossi, comment?
Yeah, absolutely. I would just second that. Thank you, Tiffany and Nadeen, for your participation, your discussion of the cases. I think it was a very nice framework for this, and your abstract summary, Tiffany, is fantastic. I'm going to be using that a lot. And a big thank you to Angie. I know she's in the background, and to everybody at AST for the support for our Controversies Conference and the invitation to present our work today. Thank you very much.
Thank you. Thank you, Dr. Lentine, Rossi, and Caza. And now we'll hand it over back to Brian. Thank you.
Thank you so much. AST would like to thank Drs. Rossi, Lentine, Khoury, and Caza, AST's WHCOP and LDCOP, and all of our attendees for today's session. Please remember to complete the evaluation survey in Zoom and visit myast.org/education to view our video archives and register for upcoming journal clubs. Thank you all for today's session.